I am absolutely delighted to introduce our speaker today. This is Dr. Kristina Warner. She received her Bachelor of Science from the University of Pennsylvania and then went on to complete her medical doctorate at the University of Rochester. She did residency at Northwestern and then joined our division as our inaugural fellow in 2021. I have to say I joined around the same time, and I think Kristina has taught me more than I could have ever taught her. After completing her fellowship, which she will complete in not too long, you're about to leave the nest. I'm happy to say that she has signed a contract with Stroger-Cook County, and she will be continuing to serve the underserved and minority populations of Chicago, which dovetails perfectly with her research in healthcare disparities in urogynecology and pelvic health. So without further ado, I'd like everyone to give a warm round of applause to Dr. Kristina Warner as she presents on preserving the apex.
Thank you for that wonderful introduction. Today, I will be talking about preserving the apex. I have no disclosures. My objectives today are to provide a historical perspective of pelvic organ prolapse management, describe current management of apical prolapse, and briefly discuss future directions. Or in other words, to talk about where we have been, where we are now, and where we're going. So where have we been? Prolapse was first described in 1835 BCE by early Egyptians as the falling of the womb. And treatment at that time consisted of applying honey, petroleum, and even manure to the prolapse tissues before they were manually reduced. In the Hippocratic era, prolapse treatment took on a more brutal form. The uterus was described as an animal within an animal, and it was treated as such. One approach was the practice of fumigation or scent therapy, where pleasant scents were placed at the woman's head and foul ones near their vaginal introitus to encourage the womb or the animal to retreat. Pessaries were also used. Prolapse tissues were frequently bathed in mixtures of wine, honey, and aloe before fruit and woolen tampons were inserted into the vagina. And so in this illustration, you can see a woman who is clearly very distressed, having a pomegranate inserted into her vagina to reduce her prolapse. In the event that these more conservative attempts were unsuccessful, harsher, more invasive attempts at taming the unruly uterus were attempted. The practice of succussion, which is illustrated here, involved binding women at the feet and tying them to a ladder in an inverted position. What is not illustrated is that while in this position, women were often repeatedly bounced on their heads to further aid in prolapse reduction. And if this didn't work, as if this wasn't enough, women were then subject to surgery. One surgeon described cutting off the black part. So after prolapse tissues had been encircled with twine and they were ischemic and necrotic, they would cut them off. And another described attacking and frightening the prolapse parts with a red hot iron. Not ideal. But thankfully, in the 16th century, with the Renaissance, came an emphasis on classical learning. Artists began more accurately representing the female form, and prolapse management evolved to be a little less brutal. Pessaries that were more similar to those that we use today emerged, and their use became quite common. In the mid-19th century, with the advent of anesthesia, surgery took a major leap forward. Surgeons were able to operate longer and experiment to develop new surgical techniques, which included vaginal vault and introital narrowing and cervical amputation. In this century, there were many firsts. The Lefort colpochliosis and the Manchester procedures were first described. The first anterior colporrhaphy was performed, and the first vaginal hysterectomy was also performed for prolapse. And as these surgical advancements continued into the 20th century, there was introduction of vaginal mesh and minimally invasive surgery. As our understanding of the etiology of prolapse improved, so did the number of surgical procedures. The Birch procedure to correct stress urinary incontinence and cystocele was perfected, and surgeons began using various autologous and synthetic grafts. In 1991, John Delancey published on the levels of pelvic support after performing cadaveric dissections. This illustration is highly reproduced in GYN textbooks, and in the simplest form, it shows that the pelvic floor muscles form a bowl of support on which the pelvic organs rest, and the connective tissue attachments, or the endopelvic fascia, keeps the pelvic organs situated in space. Level 1 support refers to the proximal suspension. You able to see that? No. The proximal suspension, which is provided by the uterosacral and cardinal ligament complex. They support the cervix and the upper vagina, maintain vaginal length, and keep the upper vaginal axis nearly horizontal. Level 2 support, or the lateral paravaginal attachments, connect to the arcus tendineus fascia pelvis and functions to keep the vagina midline directly over the rectum, anchor the vaginal sulci to the levator ani, and change the distal vaginal axis to a more vertical orientation from the horizontal orientation. And then finally, the level 3 structures, the perineal body, perineal membrane, deep and superficial perineal muscles, help to maintain the normal position of the distal 1/3 of the vagina, provide support to the lower part of the vagina, and ensure proper function of the anal canal. So where are we now? Today, our understanding of the mechanisms of uterine support continues to improve with cadaveric dissection and advanced imaging. Static and dynamic MRI has been used to better characterize pelvic floor anatomy and describe defects in the levels of support at rest, with squeeze, and with Valsalva, or maximum strain. Here you can see a few axial, coronal, and sagittal MRI images of the female pelvis. And while MRI interpretation is far, far beyond what I would like to review here today, what we have learned through MRI studies is that the levator ani muscles close the pelvic floor, preventing downward force on the ligaments with increases in intra-abdominal pressure. An enlarged genital hiatus is associated with prolapse recurrence. Cervical elongation at rest and during maximum traction is more caudal in the OR when compared to at the time of MRI, and half the degree of anterior compartment prolapse is explained by the degree of apical compartment prolapse and vice versa. We've also learned that hysterectomy alone will not address pelvic support or correct the underlying pathophysiology of prolapse. And in 2017, ACOG published a practice bulletin recommending that apical suspension be performed at the time of hysterectomy for patients with prolapse to reduce the risk of recurrence. But even after this joint AUGS-ACOG publication, numerous studies have shown that practice patterns haven't really changed much. Apical suspension is not routinely performed at the time of hysterectomy for prolapse, and practice patterns differ significantly between GYN surgeons and fellowship urogynecologists, with urogynes being 3 to 5 times more likely to perform apical suspension. For the remainder of this presentation, I will focus on the 4 most common approaches to preserve the apex: sacrocolpopexy, native tissue repairs, colpocliesis, and hysteropexy. And we'll briefly review the published data. For patients with apical prolapse, the first branch point is hyst or no hyst. Hysterectomy has traditionally been performed to expose supporting pelvic ligaments, but uterine sparing procedures can be performed for women depending on patient preference. Patients who are comfortable with hysterectomy are candidates for native tissue repairs and mesh-augmented sacrocolpopexy. And for those who aren't, colpocliesis and hysteropexy are options. So let's begin with native tissue repairs. But before I do, Let me preface by saying that this is not meant to be an exhaustive review of the surgical techniques, but more so to review the sentinel articles that inform our practices as urogynecologists. Okay, so uterosacral ligament suspension. In this procedure, the vaginal cuff is attached to the bilateral uterosacral ligaments, which originate at the cervix and upper vagina and insert at the sacrum. Is there a, no, okay. And a sacrospinous ligament fixation where a suture passage device is used to attach the vaginal cuff to the sacrospinous ligament, which extends from the ischial spine to the sacrum. Although suture-based fixation is typically performed unilaterally on the right side to avoid dissection around the colon, you can see here how mesh grafts may also be used to allow for bilateral fixation. Now to the data. In the optimal trial, women with stage 2 through 4 prolapse were recruited from 7 US clinical sites and randomized between uterosacral ligament suspension, sacrospinous ligament fixation, perioperative behavioral interventions and muscle therapy, and usual perioperative care. In this 2x2 factorial trial, women randomized to uterosacral ligament suspension would also be randomized to either behavioral modifications and muscle therapies or perioperative care. And the same was true for sacrospinous ligament fixation. The primary outcome of surgical success in this study was defined, and I want you to pay attention to this because we will revisit this and it'll come up a couple other times in some of the studies that we'll discuss. But surgical success was defined by the absence of apical descent more than 1/3 of the vagina, into the vagina rather, prolapse beyond the hymen, symptom bother, or retreatment. At 2 years, there was no significant difference between surgical success, serious adverse events, and retreatment between groups, and neither of the two approaches was superior to the other. In the extended optimal trial, which reported on 5-year outcomes, success was noted to deteriorate over time, and approximately 2/3 of patients met the failure definition, but there was still no significant difference between surgical procedures. As is to be expected, native tissue repairs continue to be studied and comparative literature published. In 2022, a systematic review and meta-analysis that compared the efficacy and safety of both procedures again found that there was no significant difference between the two procedures in success rates, anatomical success, or recurrence. Okay. Moving along to the other common procedure performed for patients who undergo hysterectomy, we have sacrocolpopexy, but bear in mind this can also be performed in patients who have undergone a hysterectomy, usually a supracervical hysterectomy. But here, a Y-shaped mesh is affixed to the anterior and posterior vagina. The peritoneum overlying the sacral promontory is opened, and mesh is attached to the anterior longitudinal ligament of the sacrum using non-absorbable suture or surgical tacks. In the extended care trial, which compared long-term anatomic and symptomatic outcomes in women undergoing abdominal sacrocolpopexy, prolapse failure was defined as it was in the care trial. So apical descent, more than 1/3 into the vagina, prolapse beyond the hymen, symptom bother, or retreatment. 7-year symptomatic and anatomic recurrences are displayed here, but this is quite busy. But if you look at the 7-year follow-up period, you'll see that composite failure rates were noted to gradually increase over time. And with the introduction of minimally invasive surgery came a need to study laparoscopic and robotic assisted surgical approaches and compare those to open approaches. Chang et al. In a systematic review and meta-analysis of randomized controlled trials comparing open, laparoscopic, and robotic assisted sacrocolpopexy demonstrated that while anatomic success did not differ between procedures, operative times were shorter, estimated blood loss was higher, and there were more postoperative complications with open sacrocolpopexy when compared with minimally invasive sacrocolpopexy. So in other words, minimally invasive sacrocolpopexy was proven to be a safe and effective alternative to open sacrocolpopexy. Okay, shifting now to patients who prefer uterine preservation. In the literature, common reasons for desiring uterine preservation include a desire for future fertility, concerns about how loss of the cervix and uterus may affect sexuality and self-esteem, and personal beliefs or a sense of identity. And as we previously discussed, colpocliosis and hysteropexy are options for these patients. The Lefort or partial colpocliosis is performed by removing a rectangular segment of the anterior and posterior vaginal epithelium, and then performing a suture-based inversion, first of the cervix and then of the vagina, while leaving lateral draining channels. A concomitant levator myopathy is often performed where the bilateral levators are plicated in the midline to increase posterior pelvic support and narrow the introitus. And hiatal narrowing has been associated with decreased rates of recurrence. Total and partial colpocliosis are our most durable prolapse surgeries. Rates of anatomic success and patient satisfaction are both upwards of 90% in short-term studies. In this single center chart review of patients undergoing Lefort colpocliosis by urogyne surgeons, anatomical success and patient satisfaction were 98% and 93% respectively. And the rate of postoperative complications was low, with the majority owing to urinary tract infections. So 9% of the 15.2 that you see here were urinary tract infections. Winkleman et al. In a single center cohort study of patients undergoing both total and Lefort colpocliosis showed that with longer term follow-up, so in this case, a median of 6 years instead of 25 weeks, there was a decrease in both anatomical success and patient satisfaction. So in this study, you can see that anatomical success was 94%, but patient satisfaction decreased to 78%. Interestingly, in this study, satisfaction or the lack thereof was not associated with symptoms of prolapse, but instead with urinary and fecal symptom sequelae. But colpocliosis, again, remains an excellent surgical option for patients who no longer desire vaginal penetration and have no contraindications. Last, but certainly not least, in one study, 36% of women indicated that they would choose uterine preservation, assuming equal efficacy. As a result, more hysteropexies are being performed and more studies published comparing hysteropexy to other prolapse surgeries. For hysteropexy, the native tissue and mesh-based techniques that we have previously discussed are used to suspend the cervix and the uterus instead of the vaginal cuff. And so although suture-based sacrospinous hysteropexy is the most commonly performed procedure, illustrated here is a uterosacral hysteropexy. And mesh-based sacral hysteropexy, which suspends the uterus and cervix to the sacral promontory. So here you can see, if you look all the way on your left, your right, you'll see that there's a dual leaf sacral hysteropexy, where the anterior leaf of the mesh exits through the broad ligament and the posterior mesh leaf attaches to the sacral promontory. As I mentioned before, many studies have been published comparing hysteropexy outcomes to those after their combined hysteropexy and prolapse surgery analog, and comparing hysteropexy approaches. In this multi-center retrospective cohort study, which sought to compare one-year anatomical failure rates between sacrospinous ligament hysteropexy and uterosacral ligament hysteropexy, patients who had undergone surgery by a urogyne were identified by CPT codes. And at 1 year, there was significant loss to follow-up, with only 32% of patients presenting for a pelvic exam. However, for the primary outcome of anatomic failure, which was defined as any prolapse beyond the hymen, There was no difference in prolapse recurrence between groups. There was also no difference in symptomatic failure. And so here it is 11.6% versus 11.4%. And then finally, there was no difference in the composite failure either. In the super trial, mesh-based hysteropexy was studied. And so 9 US clinical sites participated in this randomized superiority trial designed to compare efficacy of vaginal mesh hysteropexy and vaginal hysterectomy with uterosacral ligament suspension. Again, similar to prior studies, treatment failure was described or defined as a composite outcome, which included prolapse beyond the hymen, prolapse symptoms, and prolapse retreatment. And in this study, which included 183 participants, there was no difference in failure between groups over 4 years. Hysterectomy was associated with longer operative times and increased costs, whereas hysteropexy was associated with decreased estimated blood loss and increased risk of adverse events like mesh exposure, ureteral kinking, granulation tissue, and suture exposure. And so it was concluded that the vaginal mesh hysteropexy was not superior to vaginal hysterectomy with uterosacral ligament suspension. In the extended super trial, which provided 5-year follow-up from the super trial, the primary outcome again was composite treatment failure. And most participants met the definition of persistent success at all time points. So 66.7% in the hysteropexy group and 51.2% in the hysterectomy group. And there were fewer failures for hysteropexy when compared to hysterectomy at 5 years. So a gradual increase from year 1 data. And then finally, we're almost done, hang in there. In the VAULT trial, which compared 1-year efficacy and safety of vaginal mesh hysteropexy, so applying mesh vaginally, to laparoscopic sacral hysteropexy, applying mesh abdominally, Gutman et al. In a multi-center prospective cohort study described, again, no difference in anatomic cure, symptomatic cure, or composite cure after adjusting for baseline differences and clinical site. And of course, there was an extended VAULT trial to report on longer outcomes. And so here, 7-year data again showed that there was no difference in composite surgical success between groups. 82% for the laparoscopic sacral hysteropexy and 74% for the vaginal mesh hysteropexy. Okay, that was a lot. Let's take a moment. It's a lot for you and for me, but there's a lot of data informing our practices. And so I just wanted to kind of give you a brief overview of what we use to inform how we counsel patients and what we ultimately decide to do for their surgeries should they have apical prolapse. Okay, so you're probably left asking, what do I do with all this data? Can you run some of it back? It was a lot. What is the final recommendation? The takeaway should be that what matters depends on how we define success. So how should we define success? In 2023, an international writing group of 7 Euroguides performed an exhaustive review of 12,000 studies and ultimately used 68 of them to inform the following recommendations. For prolapse research protocols and clinical practice, surgical success should be primarily defined by the absence of bothersome patient bulge symptoms or retreatment. Or in other words, a patient's subjective outcomes should be used to determine surgical success. And so in 2023, using multi-center prospective registry data, prolapse recurrence was analyzed for native tissue, sacral colpopexy, and colpocliesis. And this 12-month data showed that there was no difference in subjective and anatomic prolapse. And so again, if we're focusing on subjective outcomes, there was no difference, and no difference in retreatment. So patients who are unhappy or bothered after their prolapse surgery are more likely to be retreated. There was no difference in retreatment between groups looking at native tissue repairs, sacrocolpopexy, and colpoplasmosis. And then finally, in a longitudinal study, comparing reoperation risk after prolapse surgery using 7-year CMS data, we saw similar results. When compared with sacrocolpopexy, colpoplasmosis was associated with 50% decreased odds of reoperation, and the likelihood of reoperation was not statistically significantly different for uterosacral ligament suspension or sacrospinous ligament fixation when compared with sacrocolpopexy. So again, colpoplasmosis, most durable procedure, likelihood of reoperation between uterosacrals and sacrospinous did not differ when compared with sacrocolpopexy. So where are we going? Just this month, this review article was published in Urogynecology, the official journal of the American Urogynecologic Society. And for the sake of time, I will breeze through this because it was also quite dense. But it discusses how stem cells, laser therapy, platelet-rich plasma, and biomaterial scaffolds can be used to help treat pelvic floor disorders. And while a lot of headway has been made with treatment of stress urinary incontinence, there are also a lot of preclinical data. There's a lot of preclinical data that's being published on prolapse as well. So in one study, platelet-rich plasma was used at the time of anterior colporrhaphy, and that was just in 9 patients. And at 20 months, POP-Q measurements did show that they were significantly improved from baseline. In another phase 1 clinical trial, we demonstrated that hydrogels, which are derived from extracellular matrices, when injected into muscles, will increase the muscle fiber area. And so very helpful for urethral sphincters, but still there's a lot of promise there. And acellular biomaterial scaffolds and decellularized matrices have also been studied. And there's a randomized control trial that looks at using porcine matrices at the time of anterior colporrhaphy to help promote tissue remodeling without promoting inflammation. So a very good read. I definitely recommend that you take a look at it. And I'd like to thank you for your attention. I know that was dense. But that is the data, and here are my references. Thank you.
Gotcha, Kristina. That was so well presented. Thank you. And thank you so much for including the patient-centered outcomes. So my question for you is, with all of this crazy data, how are you going to suspend the apex in your practice? How are you going to choose?
I am going to allow the patient to choose because I think it's really important, and something that I've learned a lot about during fellowship is the importance of patient-centered counseling and measuring patient-centered outcomes. And so I will present the data and allow them to inform that decision just based on their preferences. Perfect. Thank you, guys. I'd love to go celebrate Dr. Bills.